And good afternoon, and after an enlightening session, first session, we are going to the second session, which is going to deal with the robotic surgery. You know, the field of robotic surgery has revolutionized the field of surgery. And this session, we are going to have robotic in the management of oncology. This is the second session. And we have a eminent robotic surgeon, Dr.Srivathsan, who is going to be the presenter of the session. And he is a dynamic oncology specialist and specializes in the field of uro-oncology and robotic surgery. And he specializes in the endo-oncology and robotic surgery. He undergraduated from Stanley Medical College and postgraduate MS from the Maulana Azad Medical College, New Delhi, and super specialized in neurology in Skill Park Medical College. And he is the urologist in St. Isabel's Hospital and Apollo Hospital. And he is a member of so many associations, IMA, and Society of Endoscopic and Laparoscopic Surgeons, ASI, and Asia Pacific Association of Southern Urologists, and so on. So he is a very eminent field in the urology. And his main interest is going to be robotic and minimally invasive urology, endourology, reconstructive urology, and robotic uro-oncology. So that is the pioneer in the field of uro-oncology. We welcome Dr. Srivathsan. Thank you.
Very good afternoon to one and all. It's a pleasure from my side to speak in my own IMA. Dr. Kailaswara sir was the son who signed my first papers about a decade ago, probably. Can I have the... Blanca. Yeah. Apologies. Right. So this year, WHO has named the year for the cancer as the Close the Care Gap. I think we had a discussion with the last speaker, Dr. Sujit sir, how immunotherapy has reduced the care. When it got introduced, I think it was running into lakhs and crores, but nowadays we are able to offer it. Similarly, in my case, probably when robotics started about a decade ago in India or, for example, in Chennai, it was exorbitantly costly. And nowadays, with a couple of things happening in the market, both with the introduction of newer robotic systems as well as with the introduction of competition in the robotics field as well, we are probably hoping that the cost will come down over a period of time. My talk today would be the use of robotic technology in urology and uro-oncology. Mainly, I'm a urologist who has trained in uro-oncology, so I'll be focusing only on the oncological part of urology, that is the use of robotics in it. So this is how basically the robotic setup looks like, and I'm going to go in detail to just introduce the topic, how we exactly do the robotic surgery, and probably then we'll go on to the questions, and we'll show a couple of videos how exactly robotics helps us in giving a better outcome to the patient as well. Basically, the objectives of top would be the basics of robotic surgery and the utilization in urology and uro-oncology, the machine, the mechanism, and the means. I'm not going to talk about the superiority of robotics over conventional surgery or laparoscopic surgery, nor one system over the other. This is just the way robotics has changed how we do surgery as well. So why I'm talking about one superiority of one robot to another is that we used to have only one system of robotics which was there for almost 15 years, and nowadays we have, for the last 5 years, a number of companies coming up with newer robots as well. We have the Cambridge robots from CMR, we have the Medtronic robot, Hugo Ras, and we also have an Indian Make in India robot called as the SSI Mantra. So these are the ones which have come into place, and definitely that is what is going to bring down the surgical cost. In addition to that, we also have a lot of other companies, including Google, Verb, as well as the J&J. Everybody invested a lot of billions of dollars in developing what is called as a soft tissue robotics. That is the current in thing. Even the Kawasaki bike company has built a robot as well. So a lot of companies are interested in soft tissue robotics. So definitely there is going to be a definitive boom in the number of robotic systems that's going to come into the market, and that is going to definitely change the way we do surgery. Now, robotic systems are classified into three different things. One is a small system, the second is the medium system, and the large system. So you have, this is just called as a Mira robot, which is not yet introduced into the market. You can see how miniaturized it is with the camera and the lens coming through a single port, and this is how it's going to be the future of surgery, where you can go into the nooks and corners of the body without having much making a big incision to do the same. They even have lens clearing technology, like how you wipe your windshield with your wiper, so that you don't have to take out the camera every time to clean the lens and so forth as well. So this is something that is going to definitely make a lot of differences. And it all started with urology and uro-oncology, because the uro-oncologists, especially the open ones, found it very difficult to approach the prostate or the prostate cancer because of the location inside the very narrow, deep android pelvis. And in order to clear that, they needed to do a lot of exposure, and a lot of bleeding used to happen during that point of time. But if you see it, over the period, the general surgeons, the gynecologists, the colorectal surgeons, as well as the the thoracic surgeons have also started using this robotic technology to do their complex and difficult cases as well. This is the overall picture. You can see there is a tremendous increase in the number of robotics surgery that is happening over the world, including India as well. Now, if you see the graph, you can see a sudden rise in the last almost 5 to 10 years, where almost all the surgeries that has been performed with the use of robotic technology. We are also expanding our experience with the robotic technology to increase the number of cases. Exactly, the complexity of the cases is also increasing day by day. Now the question is robotic surgery the future or not? So it's no longer the future, it's already here. The cost was the only thing that was said against the robotic, but if you see the recovery period, for example, if you do a prostatectomy a couple of decades ago, the patient used to stay in the hospital for at least 7 to 10 days, with the cost incurring the antibiotics and so forth. But if you see now, there are hardly stay there for a couple of days and then they go back home. Definitely there is a cost saving in the number of stay in the hospital, the antibiotics and the resistance and all those things that can come along with it, and definitely over the period of time reduce the cost of the entire process as well. So I think if you compare it, definitely minimally invasive or the robotic surgery adds to the value of the both to the hospital as well as to the patient as well. Now we all know that change is the only constant. So when laparoscopic cholecystectomy came into vogue, the controversy was that it can never be as good as the open cholecystectomy, because you can't feel the bile duct and the cystic duct and so forth. So it was actually condemned when it came into practice. It took the last 2 decades for laparoscopic cholecystectomy to become the gold standard. Similarly, when robotics was also introduced, there were a lot of controversies with regards that the robotic technology can crash. It can go in for some misdemeanor, which can lead to problems to the patient. The surgeon is sitting a little away from the patient, so if there is an emergency, he will not be able to approach the patient, and so many other factors as well. But over the years, we have noticed with our own experience and with the literature experience that the actual the chances of error during robotic surgery is less than 0.5% or 0.05%. So when you come to that, the technology per se is not actually damaging to the patient, but it is the surgeon who sits on the console. It is whom the entire responsibility sits with, and it is his training and his quality that matters finally. So this is how it has changed from open to lab to robotic. Now we all know that we have all read sci-fi and all those things, so iRobo and everything. So robot means forced labor basically. So the first robotic surgery that was done was in the field of neurosurgery, where they used the robot to actually calculate where exactly is the brain tumor or the metastasis to point a directed biopsy at it. But what robot that we are talking about is not a computer or a technology which is used to calculate, including the ortho robots. They are all calculator robots which will tell you where to put the implant and so forth. But what we are talking about is a master-slave relationship. You go sit in a console and you move your joysticks. The instrument inside the patient's body move according to it and will do the surgery according to your command. So there is no autonomous robot movement or anything like that. It is exactly a master-slave relationship. So these are all the various surgeries that has been completed with the help of the robot, and the list is even ever increasing day by day. So what is the benefit to both the patient as well as to the surgeon? So when you compare the laparoscopic and the robotic method, definitely we all know that minimally invasive methods are making the patient recover faster. There is lesser pain, there is lesser blood loss, and definitely the recovery path is very much shortened. Patients do get back to their normal life, their normal work as early as possible. But what is the benefit to the surgeon? Now, we all know that oncological surgeries are very long surgeries. They are not like 1 or 2 hour surgeries. We do minimum is about 6 to 8 hours that we do. The fatigue of the surgeon whilst during this surgery are very much reduced when you are sitting in a console and operating, when the ease of the surgery also makes you do a complex, long duration surgery faster as well as easier on your eye and your brain without much fatigue. So this is very, very important for the surgeon as well as able to do a better outcome surgery whilst doing a very long, complex operation. The second thing is that definitely when you're doing your laparoscopic surgery for more than 2 hours, you're going to lift your shoulder, you're going to strain your arms, your hands doing the complex surgery. Whereas here in the console, you're sitting very casually with your shoulders relaxed, very not stooped, and only your wrist and your hand movement are the ones which move the instruments. So in a way, yeah, probably you may get a little bit of wrist fatigue sometimes, but then your entire body is slightly relaxed and you don't feel the fatigue whilst doing the surgery. The third most important is the vision. Because of the 3D vision and the closer vision that you have to the anatomy, you will be able to do a better job finally. So this is how a robotic surgery or operation theater looks like. You have a console where the patient, the surgeon sits in the console. You have the patient cart where the patient is intubated and the robotic, the arms come towards the patient. And then you have a stack which will show the TV and the gas insufflator, the energy device and so forth. So this is how we generally do it. The surgeon, as you can see, is sitting at a range as close to the patient as possible so that at any point of time you can approach the patient easily and fast. You're not going to sit outside the patient or outside the OR or anything like that. We are sitting right next to the patient. The second thing is that with the closeness of this, you just have to get up and go to the patient side if there is any emergency, so forth. You also have another assistant surgeon who is sitting near the patient's bedside, who will help you with the suctioning, cleaning of the instrument, and clipping sometimes and all those things. So you already have a trained surgeon along with you sitting near the patient as well as you sitting at the console doing the surgery. So as I told you, the system comprises of 3 systems. One is the surgical cart, one is the vision system, and the surgical console. I'll just show you the various system in the pictures later. So the main point of the surgical arms that helps us do the surgery better is the 7 degrees of freedom. So basically, the technology is called as the endo wrist, like how we have our wrist. there is two wristed joints in the instrument. So the first wrist moves about 360 degree and the second wrist moves about 270 degrees. And because of this, you will be able to do the maneuvers which is not possible by the human hand at a very narrow place, especially in the pelvis, and reach areas which you can't reach with your big hand and putting it into the pelvis. So this is the main advantage of the robotic instrument. This is what has definitely changed the way we do the surgery as well. So these are the robotic ports and everything. I'll just show you how we perform the prostate or a nephrectomy and so forth. So basically, the placement of ports and everything is similar to laparoscopic ports. So I'm not going to get into the details of it. This is how the positioning of the patient and the port positioning with regards to the nephrectomy and pelvic surgery looks like. So let me not go into the details of it. So this is the core technology. So when you look into the system, that is how it looks like in the this thing. It's a magnified, about almost 10 times magnification, high definition vision, and a 3D vision. Now, how the 3D vision is dealt with this, there is two rod lens system, one for the right eye, one for the left eye. Each picks up the image, it's converted, digitize it, and then you reinterpret as a 3D image. So you are able to see the depth of the surgical field, and that is very, very crucial when you are doing cancer surgery. And that is the EndoWrist technology that I was talking about. And finally, you can see the console where we sit and operate. Now, this console can be adjusted for height, where you can just move your pedals towards you if you're very not so tall and so forth. So you can comfortably sit and readjust everything to operate comfortably. So this is the patient cart, how it looks like, the arms which moves towards the patient. Just show you a couple of videos which how we dock the, I'll just skip all these things for want of time. So this is how it looks like finally before shifting to the patient. The sterile arms have to be draped because this is a sterile procedure. So we don't let the infection. All this is done twisting. So this is how we dock the arms. I'll just show you a small video. So it's all automated. So you just have to select what procedure, where the robot is going to come from. And then once you do that, you click the button and it automatically rearranges itself according to what type of surgery you're going to do, whether it's prostate or nephrectomy or hysterectomy, whatever it may be. So it does automatically, so that once it is done, it is ready to be docked. You can then shift the robot towards the patient. So I'll show you the docking video. So this is how we do it. Once you set up the entire thing and the robot is ready, you move this completely towards the patient's table and start docking the arms. So basically what the newer system of robotics has, it has a targeting system. For example, you're targeting the prostate or the uterus and things like that. You point the camera towards the organ and the arms accordingly rotates and releases itself so that you can dock the rest of the arms without each of them clashing with each other. So that is the camera port that we can attach. Once you've done that, you put in the camera and then you target at the organ of interest, for example, the kidney or the prostate. And once you do that, you can see how the arms are arranging themselves accordingly so that there is enough distance between the arms, they don't clash with each other, and then you can dock the rest of the arms. Once this is done, then you can start sitting in the console and start operating the instrument. These are the instruments that are placed inside the ports. Now you should understand that is a supercomputer that is attached to each of these robots. So whatever you move, there is hardly any microsecond delay and it is represented inside the patient's body immediately. You don't feel any lag and so forth. So this is what the vision card looks like. That is the image that the assistant surgeon sees as well. Now this was the endoscope I was talking about. You can see the rod lens system. You can see two eyes, one for each of ours. And this is the crux of the endoscope which makes our surgery better. And this 3D vision is very, very crucial. And it helps us go into very narrow places and take out the tumor as well. So this is how it looks like to the surgeon sitting on the console. You know what are the instruments you're using, what is your corti setting. You can adjust all your corti settings here itself. You can do your up and down, 30 degrees down and up, and also 6 with the camera as well. We do have newer technologies that is coming up, like vessel sealers, staplers. We can do your bowel cutting and everything. Another important factor is the ICG. Indocyanine green is one of the technologies we are using currently. So basically we inject indocyanine carbon and then you can see the firefly technology. You can see the color difference between the normal tissue and the tissue which has been perfused with the dye. So you can differentiate between which is the cancerous part, which is the non-cancerous part. This is very useful, especially in kidneys, when you want to know which artery supply that kidney, so that you don't have to block the entire renal artery, but only the artery that supplies the renal tumor. So to give you an idea how small these instruments are, that's a cent coin that is there. So you can see that the tip of it is only a cent coin sized this thing. So it's as small as that, so it helps you take a better this thing. So I'll skip all those and show you the video of how exactly we do the surgery. So these are the various lists of surgeries that we usually do with the help of the robot. So almost all surgeries in urology, except probably the endourology part, we do it with the help of the this thing. So this is a lower polar renal tumor that you can see here. So we usually do what is called as a robotic nephron sparing surgery or a robotic partial nephrectomy. So we start with basically the mobilization of the renal artery and the vein, where we clamp the renal artery before we start cutting the kidney. So that is the renal artery that you can see. We sloop it so that we can put a bulldog on it and stop the circulation of the renal artery for a certain period of time when we cut the kidney and suture the kidney. And we also take control of vein as well. We usually do not clamp the vein unless it is very close to the vein and it can, has to be sutured or something like that. So that is the vein that is looped. So once we have taken control of the hilum, then we start mobilizing the tumor and visualizing the tumor. So that is the lower pole of the kidney, and that is the upper pole normal part of the kidney. So the entire thing is the lower polar tumor that is there. So you can just mark the tumor so that you know where to cut once you have clamped the artery. So once we clamp the artery, we are on a time schedule, because there is a concept of warm ischemia time. You cannot clamp the artery for a very, very long time. So we need to keep the clamp time less than half an hour. So that is the robotic bulldog that we apply. So once the clock will start once this clamp is applied and the arterial blood supply to the kidney is temporarily stopped. Then we start cutting the renal tumor away from the kidney. So you can actually see the movement of the scissors and everything, and can appreciate how here it is probably less moving, but you can see how it moves like this and this. So this kind of a movement is kind of difficult with human hands. You can see that there is a bit of tumor here. So we'll go a little beyond. That is the tumor that is seen. So this is the normal parenchymal kidney. There is an endophytic component to the tumor. So we will go beyond that and clear that part as well. So once this is the last part, you can see a small venous branch that is there. You can clip it or even tie it if you want, depending on what you are using. So that is a vein that is there. You can see clearly. So we can use the assistant to clip it, or you can clip it robotically as well, depending on the what technology you are using. So that is the part, that is the normal kidney, and this is the tumor. Once you have removed this, then the next part comes as to how to reconstruct this defect. There should not be any urine leak post-surgery, and there should not be any bleeding. As you all know, the kidney is perfused by almost 25% of the cardiac output every minute. So this is the most important and the difficult part of this thing. And this is where actually the robotic technology comes into vogue. Look at the ease with which we can suture the kidney, and this is very difficult in laparoscopy to take this kind of a fine and move it like this. Laparoscopy is like a chopstick. You can move laterally or up and down. You can't do this endoristic. Now, that is the collecting system of the lower pole, which is open because of the removal of the tumor. You can suture that. We do what is called as a sliding clip rhinography, where we compress the kidney between the hemologs on either side, and we take all the blood vessels, all the collecting system, and then start suturing. So that was the inner layer rhinography, and then we close the outer layer of the kidney with the outer layer rhinography as well. Now this is where the robotic technology in reconstruction makes our life way easier, and the ischemia time way lesser, and the tumor clearance better as well. So another example of where the robotic technology comes into better use and maximum efficiency is basically when we remove the prostate and you have the urethra and the bladder there, and we need to reconstruct this passage. So this is, as I said, that is the pubic bone. You can see the knuckle of the pubic bone. So we are operating below the pubic bone, just above the perineum from inside. So that is where you cannot reach with your hand or your eye, and you have to really use your headlight to actually see where this location is. But you can see the ease with which we are able to suture, that is the bladder neck, and that is the urethra. You can see the catheter coming out some size during the suturing, So this is how the more very important part in this anastomosis has to be watertight. If there is a leak in this anastomosis, it will cause fibrosis here. So the patient will have incontinence for a longer period of time. So you can see that with the help of this vision as well as the approach of the instrument near this narrow area, we will be able to do the suturing far more better and watertight as well. Now, with our experience with more and more usage of robotic technology, we have started doing more and more complex cases as well. This is a case of a RCC with the IVC thrombus. So that is the IVC and the renal vein junction. So this was a case of an locally advanced renal cancer. Generally, the treatment with IVC thrombus is also removal of the RCC with the thrombus as well. So you can see the thrombus popping out of the IVC there. The main worry in using pneumoperitoneum in a large vessel getting opened is that the air entering into the vessel and getting propagated. So we need to make sure that the clamp on either side of the IVC is so. That is the other side of the wall of the IVC. You can see the entry points of the lumbar veins into the IVC as well. So once you have removed that, we then suture the IVC, and then we make sure that there is no air inside the IVC. We do HEP flush, clear off all the air inside the IVC, and then we complete the surgery as well. Now, this is one of the more difficult cases being done in the uro-oncology division. IVC thrombectomy is kind of the most complex case that we do, and this also we have started doing with the use of the robotic technology. Now, this patient goes home the second day, whereas if you do an open surgery, he's going to have a incision, complete liver mobilization, as well as here for us to approach the renal vein and the renal artery and the IVC at the same single incision. So it makes a lot of difference to the patient. When we remove the specimen also, we remove it through a fan and steel or a lower abdominal incision so that they don't have any much pain in the rib area, so they can breathe well. There is no atelectasis at the end of the surgery, which are all common complications used to occur in the open surgical era. So we are flushing the IVC with heparin saline, make sure we remove all the air, suck out all the air, and then make sure the IVC is completely closed. So that is a Gore-Tex suture. This is our favored sutures currently. We used to use Prolene, but because of memory of the Prolene, it was kind of difficult to suture. Nowadays, we use Gore-Tex, both in transplants as well as in vascular suturing as well. So definitely, the use of the robotic technology had made the surgeon's life more easier, definitely, and for the patients, the outcomes oncologically as well as recovery period very, very well as well. Thank you.